Good morning, everyone, and welcome to this session. This session is a Boston Scientific Symposium, with the theme of precision in plaque management, hybrid techniques, and IVUS imaging for optimal outcomes. I'm Chi Tang. I'm from the Heart Center here in Singapore, and with me is my good friend, Dr. Fahim Jafari from Tan Tock Seng Hospital, and we have a whole array of fantastic key opinion leaders from the region. Mark Chan right at the end there, Sim Hui Wen, who is the leader of the cath lab in Ng Teng Fong Hospital here in Singapore. We have Dr. Naratip, my good friend Dr. Chu Kim Hui from KL in Malaysia, Dr. Tori from Japan, Dr. Imran, who heads the cath lab at Khoo Teck Puat Hospital, and Dr. Jason Chen, who needs no introduction. He's actively involved in a lot of things here in Singapore. Today we have a few session objectives as usual. So we hope that at the end of this session that you would have gained a deeper understanding regarding lesion preparation techniques and their impact, especially on good procedural outcomes. We also want to explore a little bit on the complementary use of drug-coated balloons as well as drug-eluting stents in contemporary PCI practice now. And of course, we want to maximize the use of imaging, in particular intravascular ultrasound, so that we can get great outcomes for ourselves and our patients. So I'm going to hand it over now to Fahim to introduce the first talk.
Thanks. So I'm going to request Dr. Naratip to give us talk on focal force in action, optimizing plaque modification with cutting balloons. So Dr. Naratip, thank you.
Hi, good morning. Thank you for introduction. Can I get my slide? Okay. So this is my declaration. So basically, I think, now, we have many tools to prep the lesion. It depends on what type of the lesion is. If it is lipidic plaque, fibrous plaque, calcific plaque. And of course, cutting balloon is one of the tools that you should have in your toolbox. But let's talk about the design a little bit. A couple of weeks ago, I just did Basilica with my colleague, Dr. Natterwood, and we were trying to cut the catheter, and Dr. Natterwood asked the nurse, to get the better scissors, sharper scissors, and in that case, we have our surgeon on the table, and he asked, why not surgical blade? Okay, so we changed from scissors to surgical blades, and it works easily. So basically, when we talk about specialized balloon, there are many materials, but cutting balloon use surgical blades, which are very strong. And for Wolverine cutting balloon in workhorse platform, you have 3 surgical blades, and big platform you have 4 surgical blades mounted on the balloon. So it is very effective, to cut the tissue. That's why we call it focal force. Some people worry about perforation. It's not going to cause perforation because we know that the balloon height is shorter than the vessel wall. So basically, if you do not oversize cutting balloon, you will not have perforation unless it is eccentric plaque and you oversize cutting balloon. So it is quite safe if you choose the size properly. But of course, there is no RCT about it. I'll show you from imaging to see how effective the cutting balloon is. I have 2 cases to demonstrate this concept. The first one, 75, history of non-STEMI. I did PCI, LAD, and RCA 5 years ago. She had end-stage renal disease and she underwent kidney transplant later on. But after that, she came with atypical chest pain, and the MRI was positive for RCA area. And it is the picture. The previous RCA stent was occluded. The previous LED stent is patent. So at that time, I decided to proceed our RCA PCI. I thought it would be easy, but it was not. So I did wire escalation from Filter XTA to Miracle 3, Gaia Next 3, and then passed the lesion with Conquest Pro 820, very, very calcific lesion. But after that, I de-escalate the guide wire and change to Filter XTA guide wire. And I was surprised that there was some resistance in distal RCA that I didn't expect. So after manipulation, I passed through the XTA, but the Corsair Pro XS catheter could not be advanced across the lesion. Did step up, I did step-by-step predilatation and placed 3538 drug-eluting stent proximally and did post-dilatation with 35. So at that time, drug-coated balloon was not available in Thailand yet. So you saw that there is calcified nodule in distal RCA. That's where I got the resistance with the guide wire. So because of history of kidney transplant, I brought the patient back in the stage fashion, and I did IVUS. I'll skip this, but basically, you see the steel frame in the right lower corner, and this is calcified nodule, believe me. So I did rotational arthrectomy, started with 1.5 millimeter rotaburr and then step up to 1.75. And after that, I plan to use cutting balloon. So I got 7 French Geisela to extension to mid RCA, and then passed 3.5 Wolverine cutting balloon to treat the calcified nodule. This is the key picture that I want to show you. So the left upper picture is pre-PCI. You see very tight one. Right upper one is after 1.5 millimeter rotaburr. So you saw some luminal gain. In the left lower picture, you'll see bigger gain after 1.75, but you didn't see calcium fracture. Only after the cutting balloon, the right lower picture, with the red arrow. So this is where the calcium fracture is. So at that time, I was confident that I'll get good expansion. And then I placed 3.526 drug-eluting stent and did post-dilatation with 3.5, and I got good expansion to treat this calcified nodule. So this is the second one, the fast one. 51 years old, only 51, came in because of non-STEMI. So I did PCA RCA first with drug-eluting stent and brought him back for stage PCI LAD. Look at the lesion, it was not calcific. So I thought it would be easy, and again, it was not. Only 51, so I plan to use drug-coated balloon. So the middle picture is after 3.520 semi-compliant balloon. I thought it was not bad. So are we ready to place drug-coated balloon? No, I'll show you the imaging later. And the right picture is after 3.010 cutting balloon. This is the key that I want to show you. The left one is after semi-compliant balloon. You see that when you use balloon, when you do inflation, you transmit the force over the surface of the balloon. So in very tough fibrotic plaque, you see that you get luminal gain by making dissection on the other side, on the normal tissue, on the normal vessel wall. But the right picture is the result of the cutting balloon. Now you have a focal force. When you do inflation with the cutting balloon, you transmit the force to the surgical blades. And you see 3 surgical blades. You see 3 cracks on the fibrous plaque, and you got even better luminal gain after cutting balloon in fibrotic tissue. So this is my take-home message. I believe that, in some fibrotic plaque, sometimes it is hard, sometimes it is tough. So in that situation, cutting balloon, you get bigger gain compared with regular balloon. And sometimes you see a lot of slippage in very tough plaque. So cutting balloon would fix this problem. And also in calcific plaque, again, you get more luminal gain, you get more calcium fracture, you get better stent expansion. And if the calcium is not, and in Thailand, IVL is not available and it is very expensive. So cutting balloon is a lot cheaper than IVL. So I think it is one of the good options to treat it. And to combine with rotational arthrectomy, you combine 2 mechanisms, ablation by rotational arthrectomy to make more luminal gain, to get the calcium plate thinner, and then you crack it with cutting balloon. And that's the strategy that we should apply to get the good acute and long-term result. Thank you very much.
Thank you, Dr. Nartip. That was an excellent talk. So I'm now going to invite Dr. Torrey to talk about enhanced drug effect of DCB with cutting balloon, and then we'll have questions. We'll have a discussion on both the talks.
Thank you. So my talk is, just a moment, please. Could you show my talk here? So Oh, thank you. So Dr. Narrative demonstrates that very acute result of this urbarin cutting balloon. So acquire lumen gain, or to prevent severe dissections, or making a crack to the calcium. So I'm gonna have a presentation about after that. In acute gain or acute result, we know it. It's very, the evidence-based. We know that urbarin works well about it. So how about the next one? Just a moment. So can you, this urbarin and DCB usage enhance drug effect after, the DCBs? So this is my COI. So the concept is cut and drag. So if you use urbarin and cut the surface of the vessel, can this, and after that we use DCB after that. So this drug effect can maximize after, urbarin usage or not is one big question. So in Japan, we have, this is a very famous Japanese food. We have jaga butter in Japanese. It's the butter with potato. So if we cut the surface of the potato, we are sure that this jaga butter will be good, right? So cut the surface, maybe put a drug, can be good, but it's just theoretically. So we did an animal study about it. And that was published in CCI this year, 2025. So in this study, we use a healthy rabbit iliac artery model, 24 legs from 12 rabbits, and we did performed 4 types of procedures, like balloon angioplasty only, group 1, group 2 is urbarin cutting balloon only, and group 3 is DCB only, and the last one is the urbarin plus DCB, cut and drag strategy. And we did a balloon size was 3.015, and the DCB was inflated for 30 seconds. And 14 days after the procedure, rabbits were sacrificed, and we did a histopathological analysis after that. So this is a representative picture of each groups: the balloon angioplasty only, and urbarin cutting balloon only, and agent DCB only, and cut and drag strategy. Now, when you look at the green colored area with the balloon angioplasty only, there is the inner. This is the inner internal elastic lamina, the inner side of the media. This black one is the external elastic lamina, is the outer side of the media. So in between IEL, internal elastic lamina, and the external elastic lamina, EEL, is a media. So when you look at the pink one here, there's the tons of the purple colored areas that are the nuclei of the medial smooth muscle cells. And if you see that the pink colored area with the agent, DCB only groups or cut and drag groups, there's a loss of the nuclei of smooth muscle cells. So we call it as a drug effect. So maybe paclitaxel, it makes this nuclei disappear, and that makes a drug effect after the usage. So we, calculate the area or score the area of this medial smooth muscle cell loss and see what happened to the drug effect after these 4 groups. And we also check, just a moment, we also check the IEL, internal elastic lamina disruption of each groups. So whenever you use cutting balloon, it's a very, very good effect for the cutting balloon, but there is a IEL disruption here, like this. There's a loss of this black-lined internal elastic lamina. So we also measure the angle with IEL disruption or EEL disruption for the safety. So this is the main result of this study, and as you can see, that drug effect was the highest in the cut and drag strategy. So if you look at the depth of the medial smooth muscle cell scoring, cutting balloon demonstrates the highest score and was a significantly better drug effect compared with the DCB alone strategy. Of course, compared with the cutting balloon and balloon angioplasty strategy. And when you measure the angle of the severe medial smooth muscle cell loss, cut and drag again demonstrates the best angle is a 123 degree versus 52 degree in DCBs. So you may be surprised that if you use DCBs, the drug was coated uniformly, the 360 degrees. So drug effect should be expect for the 360 degree after maybe 1 month or 2 months later after the usage. But we did a lots of animal studies about DCBs, and it's kind of in the 14 days or 28 days after the DCB usage, it's like 32 degree, 50 degree drug effect in that vessels. But if you use a urbarin cutting balloon before the DCB usage, you can expect more than 100 degree drug effect to the vessel. So that's going to be good for the better patency for the mid or long term. And this demonstrates the IEL disruption and the EEL disruption. And of course, the IEL disruption was higher in cutting balloon usage, like cutting balloon groups or cut and drag strategy. But if you should know that the risk of IEL disruption was similar between the cutting balloon usage versus cut and drag strategy. So adding a drug-coated balloon after the cutting balloon doesn't mean the safety concerns. And when you look at the EEL, if you cut the EEL, I mean this outer side of the media, it's going to cause a dystenosis after that, but it was okay. It's very safe with EEL disruption was similar between the 4 groups. So this is a central illustration of this study that if you use DCB alone, maybe of course you can expect for the drug effect a little bit. But if you use add the cutting balloon before the DCB usage, you can expect for the maybe deeper drug effect with a more circumferential drug effect. So it's going to be good for the clinical outcome. Just a moment. So in summary, the urban cutting balloon before DCB usage demonstrated a significantly higher drug effect compared to the DCB alone strategy. And using urban cutting balloon before DCB was useful not only for the optimal vessel preparation, but also for the enhancing the drug effect to reduce the risk of stenosis. Thank you for your attention.
Thank you. So I think we have a few minutes for some questions and answers. Maybe while everyone on the panel is thinking of questions, I could just ask Dr. Narotip to just comment for the audience. How do you size your cutting balloon, and how do you decide what pressure to use? Because I think these are very important, pragmatic questions.
So I use 1-to-1, but sometimes I round out a little bit. Let's say I usually use imaging guidance PCI before cutting balloon. You can do 1-to-1, but sometimes I round out like a quarter size, like from 3.0 to 2.75. Pressure is a tricky question because basically Wolverine balloon is built on low pressure, non-compliant balloon. It is built on low pressure, non-compliant emerge balloon. So it is non-compliant. So you can go quite high without rupture. But so basically by IFU, they'll tell you to go low pressure. You go like 6, 8, but in my practice, sometimes I go high because it is non-compliant. It is sometimes I go to like 14, 16, 18, but be careful because if it is rupture, if the balloon is ruptured, it is you'll have difficulty getting it out, and there are surgical blades on the balloon. So I think you have to balance the risk and the benefit, but keep in mind it is non-compliant balloon.
Thanks. Dr. Tori, okay, you got me quite hungry with that potato picture. But I wanted to ask you, did you also examine whether there was any difference with other types of lesion prep, or is it just purely cutting? Or because nowadays we have other options like scoring.
Yeah, you mean the scoring balloons? Scoring balloons. Yeah. Actually, there's tons of scoring balloons here, but we are now evaluating it right now. So we're gonna show you the data maybe hopefully next year.
Okay.
Yeah.
Yeah.
Maybe I had a question to Dr. Tori. This was on normal arteries, right? Normal porcine arteries. Right. So does the same data, by extension, apply to atherosclerotic arteries? Because, or would it be different? Because for atherosclerotic arteries, you have disease everywhere, and you're cutting focally on just a couple of points. Mm-hmm. And so does the same concept apply or not?
That's a very interesting question. Actually, I'm doing the pathological evaluation of the atherosclerotic, human atherosclerotic plaque also. And if you use this cut and drag strategy to the fibrous plaque or the lipid-rich plaque, maybe it may work well for the better distribution for the drug effect. But when you look at the calcified region, especially when calcified region is more severe, and that calcified region can go to the surface of the vessel. So there's nothing on the calcified region. So in that case, you can cut your calcium on it, but the drug effect cannot expect it to that severe calcified region. So it depends on the plaque types, I believe.
Maybe I can ask Mark, do you typically prepare your lesions with cutting before you use the drug-coated balloon, or is that something you use for certain lesion subsets only?
I think cutting or scoring is a useful adjunct because the whole point of having the drug is to get the anti-proliferative drug delivered to the tunica media. And that's where the action is in terms of in-stent restenosis, because we know that it's smooth muscle cells that in the tunica media that actually convert to neointimer. So yes, I will frequently use cutting or scoring balloons so that we can get good drug penetration into the tunica media to improve the efficacy of the DCB application.
Okay. Any other questions?
One question. So in cases where we do combination rotatripsy, I was just wondering, have you guys tried Wolverine before opening IVL? Because IVL is not available everywhere for deep, thick calcium plates. Does Wolverine work well in those scenarios as well after plaque modification with rota or orbital?
I think it's about using cutting after rotational atherectomy. Is that right? Yeah.
Yes.
Because you don't have IVL in.
Yes, I use it a lot because I'm very aggressive with my rotaburr and heavily calcified. Many situations that I use one. Normally, my default is 1.75 burr, and sometimes I use 2.0. So I think I'm very aggressive, and in my practice, I think rota cut always works for me because I'm aggressive with my rotaburr, and when you have small calcium left, I think just cutting balloon can crack the calcium.
Yeah, I mean, it is important to be aware that the randomized data, the RotaCut trial was a negative trial, but what they did is they used 1:1 cutting balloons at low pressure, and so perhaps the pressure may have may modulate the response to cutting balloon.
Yes, I agree with that because, like I said, IFU said low pressure, but when I go high pressure, I think I see better results sometimes with imaging.
Yeah. Okay. So,
Yeah. Okay. Any other questions? I invite some questions from the floor. If not, then we will move on to the next section, which is really quite exciting. I'm getting quite excited thinking about it. So okay, I think if there are no other questions, we will move on. So the next bit is we're going to show a recorded case, which was done by doctors Mark Chan and Sim Hui Wen at the site there, and I think Jason was also involved. So what they were going to do is we're going to play back the recorded case, and during the playback, Hui Wen and Mark will give commentary. Jason is the expert IVUS commentator as well. So, and then we are going to do some questions whilst this thing is going on, and we're going to try and keep it interactive and thought-provoking, and then we'll take some discussion at the end. Yeah. Okay, so hopefully this works. Yeah, I had sleepless nights thinking about this, but I'm sure we're gonna pull this thing off. Okay, so Hui Wen, over to you.
Okay, so I'm just gonna give a quick background of the patient. We have no conflict of interest. This is a 58-year-old lady. She has background of hypertension, hyperlipidemia, and diabetes. She had a VSD, had open repair done before, AF and asthma. She presented to us with shortness of breath on exertion. Her labs are all unremarkable in terms of hemoglobin and, Okay, so hemoglobin, renal function are all unremarkable. Echo showed normal ejection fraction. ECG were okay. And this was the angiogram on the left side. As you can see, there was a calcified proximal to mid-LED lesion with heavy calcification. The circumflex was okay, and the RCA was just minor atheroma. This was a CT coronary angiogram. As you can see, there were heavy calcification with a calcium score of 719. In the LED, is 353. So this is a lady with a calcified osteo to mid-LED disease. We did a FFR. The FFR was 0.78, and patient was offered actually CABG because of the heavily calcified lesion. However, she declined. She came back for a PCI. So this was the strategy. So we plan to go with with radial access, 7 French. And first, we will use the intracoronary imaging to assess the calcification and to decide what device sizes we want to use. And because of the heavy calcification, as you can see on the angiogram and also the CT angiogram, we want to go for out-front atherectomy plus cutting balloon. And then subsequently, we'll reassess and see whether further devices like if IVL balloon is needed. And for this case, we aim for a hybrid DES plus DEB with a crossover stenting to the left main. Okay, so over to you, Mark.
Okay. Here is the initial invasive coronary angiogram. You can see the images on the right, and before this, you saw the AP cranial image. Now you're seeing the RAO caudal images.
Yeah.
The initial IVUS run. Maybe Jason, you can tell us a bit about what you're seeing. This is the pre-PCI IVUS. We haven't done any kind of treatment just yet.
So I think this IVUS run really tells us a lot of information. It does show eccentric calcification. It tells us that the calcification is superficial. And it really tells us the sizing of the vessel, which looks to be quite sizable. And the fact that the IVUS could cross is another feature that we would like to highlight as well. We do see some nice concentric calcification here, but pretty large lumen. So I think that will go into consideration of what devices and sizes that we're going to do. We do see quite nice wire bias touching the calcium over there. And I think we're coming up to the proximal LAD, and it does confirm the angiographic findings of very diffuse calcification. I believe we're on the left main, no, that's the ostium, maybe? That's the.
Maybe.
So if you look at the sort of the measurements, perhaps. Dr.
Maybe we
Chi Tang
could just
can decide.
pause. Sorry, can you get near to the laptop and maybe just pause it, and then we can discuss a little bit about the IVUS findings?
The strategy.
Yeah. If you could go back a little bit, yeah. Okay, all right, this is perfect. So thanks, Mark, Hui-Wen, and Jason for preparing this case. So I think the strategy you mentioned just now was upfront rotor, and you have a 7 French guide, so I guess you have a whole buffet of sizes. I typically use only 6 French, so I don't have that much sizing to play around with. So maybe question to Mark, how are you going to use these findings now to decide on your burr size and why?
Yep. So I think imaging is very helpful. In the standard practice would be to get the EEL reference distal. So in this case, the diameter averaging about 3.5 millimeters. So we halve that for the optimal burr size of 1.75. You may or may not want to go straight away 1.75, especially you're just starting at rotor ablation. Maybe start with a smaller burr first and upsize. But about a step down of 50% from the reference EEL distally. That would be the standard practice.
Okay, so you go half EEL diameter. Okay, so I mean, we try to have some active interaction. So I think, Fahim, we discussed this earlier, and I think you mentioned that there is a lot of calcium on the CTA, but is there really a lot of calcium on the IVUS that you think needs?
So it's actually quite interesting. So based on the angiogram, there's a ton of calcium. Based on the CT, there's a ton of calcium. So actually, I agree with the fact that ablation would be your first strategy. I think on the IVUS, what you are seeing is a lot of calcium. The IVUS calcium score is high. You see concentric calcium. You see 270 arcs of calcium. I think the only issue will be that the lumen, as Jason pointed out, is pretty big. So if you go even with a 175 burr, which I think absolutely I agree with Mark, that's a good starting point, you may not get as much ablation as you would like. And so then your next option will be to either go with a higher, and upsize the burr, or think about using orbital, or go with device combination or synergy, which means you do some rotablation and then you do something else after that, cutting balloon or IVL or something. So that's how I would think about it.
Okay, so in this case, you're okay with starting with a 175?
I think so, yeah, I agree, yeah.
Okay. All right, so maybe, Mark, you want to show us the 175 burr? Here we go.
No, this one goes back to the start.
Oh, this is going backwards.
Sorry about that.
You know, technology.
we use
It's always
this?
like this.
Sorry.
Yeah,
No,
oh, there
no,
we
no,
go.
touch, because this one is a single video.
Okay, we promise we're not going to pause this video anymore so that.
Okay.
Move forward.
All right, this is.
Unless there's a picture of a potato.
Yes, that's right. Potatoes, we will pause. Okay, Hui Wen, you're doing something here. This is your master technique, I think. Yeah.
So this is a one-hand rota, advanced rota ablation. It's actually to give full control for the operator to actually advance it, so you don't have to depend on the assistance. So what you do is that the left hand will actually push in the burr, and then the right hand actually pull out the wire with the brake. You have to release the brake, and then you pull out the wire with your right hand. So they give you full control. So let's give an introduction about the new Rota Pro. So the new Rota Pro actually is easy to use. There is actually no more foot pedals, so everything is actually on the advancer. You just have to press the advancer to activate the rota. And then you have a console that is quite small, and actually it will show you new features, like it will tell you when there's a rota decelerate. Yeah.
Thanks. Wow, that's very impressive. I can't do that, so I'm old-fashioned. I need help. Yeah. So
Yeah, me too. Me too. Yeah.
So give me they started rota. What speed would you typically choose, and any difference? High speed, low speed, that kind of thing.
I normally start at 170, 180. We know that the higher speeds give you more penetration force. And sometimes if you lower the speed to maybe 150, 160, there's a bit more wobble of the burr head, and so you get a larger arc of ablation. So in a large vessel like that, I might go down 150 to 160. And also if the wire bias is not in favor, I might step down to have a larger arc of ablation.
Right. Okay, Dr. Tori,
Yep.
Japan does quite a fair amount of rotablation and
Yeah, exactly
sometimes
right.
quite aggressive. 175 looks big to me, but is this big enough for Japanese style?
Thank you for your question. Of course it depends on the vessel size.
Yeah.
After you use this 1.75 rotor bar, check the IVUS. If the modification that is not enough, maybe you're not hesitate to size up to the 2.20 bar.
Right. Okay. Imran, would you use rota or you go OAS or IVL?
Well, in this case, I think to be being unbiased, both rota and OL is fine. Orbital will work as well. It's a big vessel, fairly straight tube, not much bands. Eccentric calcium distally, concentric proximally, and vessel is 3.5. This is an ideal case for orbital as well. After debulking with either rota or IVL, you can reassess and decide about cutting versus trip C, but I think this is a nice case to do any device you are familiar with.
Okay, so I think whatever you're familiar with probably is actually quite critical. Dr. Nartip, you wanted to say something? Yeah.
Yes. I think in this case, there are two strategies. I think you can use 175, but I would choose extra support rotor wire rather than floppy to get more bias, to cut more. But personally, I still like to use 2.0 because I think to get burr to artery ratio like 1.5 to 1.6, you get better luminal gain, and it is just a focal area that I think I can. I might use 2.0, but I will focus on the tightest one, not to go all the way through. That is my approach. I think orbital you can do it, but I still like rota because it is faster.
Right. Okay, so I think we saw some of the angio. I mean, there was no complication there. Good flow, vessel architecture is preserved. So I think the next bit you were about to show us the IVUS. Is that right, Mark?
Yes, this is the post rota IVUS, and maybe over to you, Jason.
Thank you. So far, looking pretty nice distally. And we're starting to see maybe a little bit of perivascular hematoma, maybe some, you can see some calcium modification, especially where the wire bias was. You see actually a luminal gain, as well as some concavity from the rota burr, probably. Over here, the wire bias is not so favorable as eccentric calcium, so not much modification over here. There are some reverb artifacts here, probably some modification done over here, so that's good. Not so much heavy disruption of the calcium over there. And I think we're coming up proximally some minor disruptions at about 2 o'clock. And I think back in the left main here.
All right, maybe we pause here. I think Chi-Teng, you wanted to kind of ask around what would be the next strategy, right? Whether we would upsize with a larger burr or whether you would use a cutting balloon or other strategy for lesion prep following the description from Jason.
Yeah, absolutely right. So I think we can see what you did, but maybe just a quick kind of a poll around the table. Would anyone do more rotablation now or upsize to a 2.0 or go IVL at this point?
So I changed my mind. I think, after I see this, I was run, I think we did enough.
Yeah.
So I think 175 per is enough in this case.
Okay.
Yeah.
Imran, yourself?
Probably need to work more in the proximal zone. So I will probably use cutting, and if not, then IVL as well to make it even bigger.
Okay.
I mean, as expected, the effect is modest. So you need to go on to the next device. I think in balloon or cutting balloon would be a good strategy here.
Yeah. So Mark, what do you do?
That's what we did. I think we thought we had initial lesion prep with the 1.75 rotabur. Essentially, that helped modify the superficial calcium and superficial aspects of the plaque. With a cutting balloon, of course, you get deeper expansion and you get into the tunica media. And the rota before the cutting balloon does make the procedure more predictable, less chance of uncontrolled dissection during cutting balloon inflation, which is what Hui Wen did very well. She did the entire procedure. I was just wiping wires for her and injecting contrast, basically.
But Hui Wen, that balloon has a bit of a waist still, right? Just now, I mean, is that acceptable? How do you decide whether to go higher?
So if it's the part where I want to do DCB strategy, I think anything less than 30%, I think it should be fine.
Okay.
Yeah. Otherwise, we can use the IVUS to reassess again and see what we need to do further.
Okay.
Yeah.
So Fahim, I think just now you asked Dr. Narate a few questions about how to inflate the cutting balloon, right? This is something that you have a particular passion about. So maybe you want to share your expertise.
I don't know about passion, but I mean, I think the issue with Wolverine size and pressure is a bit complicated in the sense that if you look at the randomized data, the COPS trial, high pressure cutting balloon angioplasty was better than non-compliant balloon in terms of luminal gain and achieved stent area. Clinical outcomes were the same, but in that trial done by Colombo and colleagues, they undersized the cutting balloon. Subsequent to that, the rota cut, for example, cutting balloon 1:1 size at modest pressure, about 12 atmospheres, was not effective. And then very recently at EuroPCR, we had the, I forget the name, I think it was Prevent Nears study, where they actually showed that multiple cuts at modest pressure were actually more effective. And so I think that my own practice is to slightly undersize the cutting balloon and then do multiple cuts. So death by 1,000 cuts kind of thing, the Japanese traditional model. I think that works very well for me rather than just one or two inflations at high pressure.
Okay. Mark,
Yep.
you got the...
So this is the post-cutting IVUS. Over to you, Jason.
So Jason, we're looking for features of successful cutting, right?
Right.
What are we looking for actually? Yeah.
So I think if we look at this IVUS run, I mean, I do see cracks in the calcium. We do see luminal gain and nice cracks. Actually,
11
almost
o'clock.
like the
Yeah.
triangle shape
Yeah.
that we are seeing on the Wolverine. So you can really see some good effect going on at that concentric calcium. And I think that really gives us a confidence now, seeing these cracks.
Dr.
that we're
Narate,
gonna-
is it ready for DCB or DES or...
Yes, it is very beautiful. I think we are ready.
Yeah, ready? Okay.
Okay, let,
Okay,
me,
so
just,
Mark,
let me just pause here.
Yep.
And I think maybe, Jason, you were commenting on the
Yeah.
where the fractures are seen
Yeah, it
and the
looks-
reverberations, the
Yes.
location.
Yes, this is a very nice slide which shows where the three cutting elements are, really applying that focus force that Dr. Nartip showed us in his earlier slide as well. So you can see the nice effect from Wolverine.
Okay, so I think the strategy that you suggested that you were going to do, Hui Wen, was to now use a hybrid strategy, right? DCB first, yeah? Why DCB for this part?
So to put it simply, hybrid strategy is you plant a stent in the proximal larger segment and then you use the DCB in the distal smaller segment. So this one will actually reduce your metal, and you know that stent length is a risk factor for ISA and stent thrombosis. So this also actually gives the opportunity for patients to have a chance for bypass in the future in case they need it. So less metal is better. So that's why the hybrid strategy. So this patient, we implanted a 3528 Synergy DES and also a 3030 agent DCB distally.
Dr. Narate, how do you size your DCB?
3.0.
3.0 based on the IVUS? Because they chose 3.0. Would you have chosen?
Yes, I would choose 3.0. I think basically I match the vessel, but you don't go too high because DCB is not the way you prep the lesion. It's just the balloon that you deliver the drugs. Yes, I would choose the same thing.
Okay. So give me, you do a lot of DCBs after in Malaysia, right? So I think the reservation that a lot of people have is when they do the IVUS after lesion prep, especially if they use things like cutting balloon, etc. It looks scary, right? Scary in inverted commas. A lot of dissection planes. I think we saw the still frame there. How are you comfortable with using a DCB, and is there any point where you won't use a DCB based on the IVUS findings?
Yeah, I agree that if you use DCB strategy, don't even look at the post preparation imaging. They're going to be ghastly. Look at angiographic dissection, A and B, non-flow limiting. I will accept that.
Yeah. Okay. Yeah, I think that's borne out by actually anecdotal, and all the case experience that we have already. I think sometimes we get scared off by the IVUS. Actually.
Yeah, but the dissection data is really related to stent and dissections. The adverse data for dissections in just balloon only is not that substantiated. Yeah. So I agree. If it looks good on the angiogram, just leave it and go.
Yeah. But Imran, I mean, there are, I suppose, some situations where you need to stent bail out, right?
Yeah.
What kind of situation would you bail out?
So if the dissection is more than type B, C to F, flow is down, ECG changes, chest pain, and residual disease, I will say the recoil, immediate recoil, or your prep is less than, residual is less than 30, more than 30%, I'll probably just, because it's still in this specific case, we're in the proximal zone actually. So stents will be fine as well if needed for bailout. Problem is the distal disease where you intend to re-be actually intentionally, like small vessels. In those scenarios, you probably prepare longer is better than, but in this case, I think it's fine.
Okay. So Mark, it looks like it's a crossover stenting strategy. Quite a big circ. Dr. Tori, would you crossover stent, or would you aim for the ostium of the LAD in this situation?
For this case, there is a sheet, very sheet qualification at the ostial LAD. Maybe we can finish with our procedure with ostial stenting. But this patient was 54 years old, right? And hybriding risk is not that much, so maybe we can cross over too. Yeah. But I would go ostial stenting.
More than one way to get a good result, I guess. Okay.
I think although the data is limited, I think to treat bifurcation, if you use DCB at ostial LAD is another option since angiographic result is very good. I think 3.5 DCB proximally is another option.
Yeah. Okay, but I think the crucial part is being shown here, where if you do crossover, then you really need to get a good pot at the bifurcation. So Mark, how do you do a good pot? You seem to have chosen a certain size, and how do you place it and things like that? Yeah.
So we chose the pot balloon based on the IVUS imaging of the left main. It has to be a short balloon, avoid the bifurcation. And of course, after doing the pot, make sure that you re-image to make sure you've got good apposition of the stent in the left main. This is particularly important because we went into the left main and not just stayed at the ostial LAD as some of our other discussants would have done.
Okay, so Jason, we're coming to the end of this section. So can you want to highlight anything on this final IVUS run?
So I think we do see some subintimal dissections. We see the stent coming in, and the stent actually look nicely expanded, very nicely opposed, and I believe the MSA is probably going to be quite satisfactory. So there are some nice features on the DCB. I think we got good luminal gain at the distal part, and also I think the dissection planes do tell us that based on the animal model studies and things like that, we're going to have good result and reduce late lumen loss. So I think it's a nice result.
And this final angio looks fantastic, man. Yeah. So maybe Mark, one final takeaway from your case that you want to share with the audience before we close this section. Yeah.
I think DCB is a viable strategy with sufficient trial evidence showing good long-term outcomes. Especially for patients with diffuse disease. Very importantly, adequate lesion prep, as we have explained today. In this case, we use a combination of rotational atherectomy and cutting balloon preparation because you really want to get maximal delivery of the drug into the tunica media so that you can get the lowest incidence of post-DCB restenosis.
Thanks, Mark. Thank you. Thanks very much for sharing the case with us.
Okay, our next speaker is Dr. Gim Hui Chu from Malaysia, who's going to talk about paradigm shift in modern drug-eluting therapies. Gim Hui.
Thank you very much, Fahim. So when we saw this result by Andreas Grunzig 50 years ago, that beautiful result in the proximal LAD was actually due to both vessel stretch and dissection. The only problem with that dissection is that you have problems with acute closure, and of course, POBA is not the best in terms of restenosis risk. When we had DES, we thought that was a panacea of all our ills, and the results had lasted until 4 years. But then only we realized that, you have a full bladder, you got to go. So Nike says, just do it. At that point in time, for us, just DES it. DES anything, left main, CTO, whatever it is. But it is the inconvenient truth. Because what we actually have is a solution, but with additional problems. We have problems with late stent thrombosis, problems with caging of the vessel, and inflammation. So what we want is a therapy whereby whatever we needed will be gone after a few years, and we have nothing left behind. So that concept was right, and we thought we got the right track. We had BRS, but the BRS technology wasn't ready. Because we saw there's worse outcome, TLF, as well as more device thrombosis in a 3-year follow-up. So we've gone a full circle from balloon angioplasty, DES, BRS, and now back to POBA. But it's actually a DCB POBA. It's back to the old device, but it's upgraded Mercedes-Benz. It's an effective way to deliver the drug to the vessel wall, but without leaving anything behind. Because of the mantra, we want to have nothing behind. So that's a good concept. And we know without caging the vessel, with a drug-coated balloon, we can, with paclitaxel-based delivery or therapy, we can have positive remodeling of the vessel. This may be the main important summary slide. DCBs today is very easy to apply, and it's never meant to replace DES. It should be part of our PCI strategy. The concept of leave nothing behind is actually great because we don't have issues to deal with in terms of the metal implant. Therefore, we can think about DCB to be used in many complex scenarios. As long as you go according to the rules, the good preparation of the vessel, you can apply the DCB. But we have to relearn what we learned many years ago of how to do a good balloon angioplasty. And not all DCBs are the same. Today, I think we are clear in terms of DCB application for in-stent restenosis and small vessel. We are expanding to a lot more complex scenarios like CTOs, bifurcations, long diffuse disease, and so on. ISR is actually the main indication. The Asian IDE trial showed a better outcome compared to balloon angioplasty alone for in-stent restenosis. It's very clear. But the European guidelines tell us that DES, putting a DES for ISR, has upper hand against DCB. One of the main evidence that actually led to this recommendation